Hello, everyone. Welcome to Ardexia Insights. I'm Dr. Aditi Joshi, and this is where we cut through the hype to explore healthcare innovation that actually works. Each episode, I talk with leaders and practitioners navigating digital transformation, telemedicine, AI, RPN, and using all types of digital tools and how it affects system change. We share real stories from the trenches and practical strategies for creating healthcare change that people can trust. So this week, I'm really excited to have my friend and colleague, Dr. Minal Shah. Dr. Shah is a hospitalist, physician informaticist, and health technology leader at CommonSpirit Health, one of the largest health systems in the U.S. Her North Star is protecting clinical judgment and the patient-physician relationship as healthcare becomes more digital. She designs and implements clinical workflows at scale across EHRs, virtual care, and applied AI, and supports more than 25,000 providers nationwide. Wow, yeah. Her work focuses on ensuring technology earns its place by reducing cognitive burden, strengthening trust, and enabling clinicians to practice medicine more effectively. What makes Minal's perspective invaluable is that she's living in the tension every day between what technology promises and what clinicians actually need. So I'm super excited to have you here, Minal. Thank you for joining.
Thank you. Yeah, I'm excited to be here as well.
So I'm going to start out with what you said about your North Star because I find that so interesting and really key to what a lot of us want to do in health technology. Protecting clinical judgment and the patient-physician relationship as healthcare becomes more digital. So that's a really powerful framing. And what made you realize that clinical judgment needs a type of protecting? And what do you feel like it needs protecting from?
Yeah. Well, I think over the last decade, we have all noticed that physician autonomy has been slowly shrinking. Physicians are getting squeezed from all angles, essentially, whether it be from insurance companies with prior authorizations, the sheer volume of patients that we are expected to see, the documentation burden that our clinicians have to bear. And of course, technology also does play a role in eroding physician autonomy sometimes. And so in clinical informatics, I think of us as stewards of clinical judgment. I think we recognize that technology can not only shape behavior, but can affect burnout. And so for me, protecting clinical judgment, it really starts first with protecting a clinician's focus. So if we can enable a clinician to focus on their patient, if we can allow them that focus and attention, then in my opinion, we are already enabling them to use their best judgment by clearing out some of those distractions.
That's such an important point. I'm sorry. I was just going to say that what you're saying is that we have so many things trying to pull at our time. So many people have talked about what that is. Is technology making it worse? We have social media, we have all these things on our time. But you're also talking about the fact that just in general, healthcare has become more complicated. And so there's so many things that we need to do at the same time, making it a much broader practice needs than previously. And so when you're talking about, centering and creating these clinical workflows at scale to really help the clinical workforce while implementing technology, how do you decide what the difference is between, or how do you go about implementing that tool, deciding the workflow that actually works in what you've seen in your experience, and what do you actually feel that works and what doesn't?
Yeah, so we look at many factors. I think anytime you're trying to implement technology at scale, you really need to dig deep into the problem that you're trying to solve. I think that there is a tendency for us in the technology realm to get very excited about new things and to try to design solutions before we fully understand a problem. And that is really the first step in designing a workflow that is actually going to be accepted and adopted by your clinicians. We want to help clinicians feel like they are supported in making clinical decisions and not feel like they are just checking boxes. We want to be able to create a workflow that supports them in executing rather than adding barriers and obstacles for them to be able to do what's best for their patient. We want to be able to make the right thing to do the easy thing to do.
Yeah, here, making it easier, right? And it's interesting too, because there was that entire book, right, by Atul Gawande that was true that we need checklists also for safety, but we can be a victim of its own success if that's all we're doing and doesn't allow for some of that tech and implementation and that clinical judgment to also work. So that's really interesting. what you were talking about. What's interesting about the type of work you do, you're seeing it across states, you're seeing it much more universally. And how do you look at, when you're talking about designing it specifically, things that can be used in a broader space versus things that are very localized? What do you see that works and what actually helps you navigate and kind of dig down and dig deep into it?
Yeah, I think that is always a tough balance when you're designing systems, especially for a large group of clinicians, balancing that standardization versus that individualized or more judgment-based approach. I think that there are definitely best practices, evidence-based practices. We want to be able to design systems that support that. We want to be able to sort of lift the bar for excellence for providers. But you and I both know that patients don't fit neatly into a box. And so there are many situations where you may have to deviate from what the best evidence might show. You might have to deviate from what a guideline might show because patients are individual and there are many factors at play when making decisions. So when we're designing for standardization, I think there are three key approaches that I focus on. The first is minimizing interruptions when you are presenting choices. The second is allowing an off-ramp for a provider who wants to choose a different path than what is recommended to them. And then learning from the variability in how folks use a tool. So I'm speaking specifically about clinical decision support type tools. So there are a variety of tools that we can use that are at our disposal that don't necessarily interrupt a provider as they're trying to make a decision. There are things like setting defaults, having tiered choices depending on the clinical situation, having checklists, as you mentioned, can be helpful in certain situations, framing alternatives so that you can very easily see what your choices are and what some of the risks associated with them might be. And of course, things like just-in-time nudges, which are interruptive in nature and are reserved for the places where you really need to make a clinician stop and think. But in each of these situations, we do have to also build these off-ramps. So we have to allow for some user-level personalization for them to choose a different path. We have to allow an easy path for them to click no and say, I want to be doing something else instead. So we have to build that into the design of a tool. And then the third, I would say, is really learning from that variability. And so when we design a clinical decision support tool, we need to be looking at what the adoption is. What are the actions that people take based off of a clinical decision support tool? If you're deploying a tool and you are seeing that the majority of providers are not acting on an alert, that is a lesson for you as the designer. Either this is a problem that's not important to a clinician, or this is a tool that is designed poorly, and you need to, take that back and redo what the design looks like. And I think too, clinical judgment, we sometimes equate clinical judgment with medical knowledge. And I think we have talked about this before, but clinical judgment is so much broader than just the pure medical knowledge or like the data synthesis piece. It is really about understanding the context of the patient. It's about other factors like readiness, values, ethics, judgment. All of those things are playing a role in the treatment plan that we create for our patients. So judgment lives in that gray zone, and you can't really standardize every single approach to it.
That's so fascinating. And I like that you separated that out, that clinical judgment and medical knowledge. This goes into a lot of discussions that we tend to have, or we have about AI in medical discussion groups, because there is that difference of the AI being able to give us that knowledge, but that judgment, as you beautifully put it, is very different. And so, taking that to that whole idea as we talk about AI and safety at scale, there's a lot to talk about in that, but I wanted to start with what you were talking about in building its place and talking about trust in it. Because if we don't, like, how do you actually build trust for clinicians who understand somewhere inside them that there is that difference in the judgment and then the medical knowledge that the AI is bringing, and making it so that they feel that trust when you're building and implementing it?
Yeah, so that's a great question. I do think that you need to really understand their approach and their thought process. So, I I practice hospital medicine. I know my lane pretty well. I actually know workflows for many other specialties quite well just because I support them with the EHR and other tools. But when I am designing for a specific workflow that I'm not familiar with, I bring in other subject matter experts, other clinicians in that area. I ask them to explain to me what their thought process is as they are making decisions. So having that additional clinical context is huge. And it goes a long way towards building trust. I think that the other piece of this is you have to pick a problem that clinicians actually want to solve. You'd be surprised how many solutions are built for problems that nobody really cares about. And I think that you have to speak the value language of a clinician when you're trying to earn trust with that clinician. And so when you're speaking to a clinician, you want to talk to them about how is this going to give you time back? How is this going to make you more efficient? How is this going to help you provide better care for your patients? How is this going to help you achieve success in certain quality metrics that you personally care about? Those are the ways that you can get a clinician on board and earn trust. And I think a big part of it is you start with a group of early adopters who are willing to learn and experiment with you, and then you really use those as champions to gain the trust of other clinicians. I think that that physicians are much more likely to trust their colleagues than they are to trust outsiders. Even myself, as someone that's in informatics, I can sometimes be seen as an outsider. Leveraging that trust between clinicians is really key.
I completely agree. I just think about my experience at Jefferson, and I probably told you this, that it helped a lot that I was actually doing the same thing. And I was, when we're talking about telemedicine, I was doing it as well. And that really does go a long way to crossing that chasm. You'll get the early adopters, like you're saying, but to actually get that middle group, the biggest group, it does take a lot of that trust and implementation. So for you as an informaticist now, taking it a bit toward the AI, so a lot of discussions are about reducing cognitive burden for clinician. That's actually where the most excitement happens. When you're using it or you're talking about it, do you actually see that it's reducing cognitive burden? Or at the moment, are we just shifting that burden onto something else or adding to some of the burnout that goes into clinician workload at the moment?
Yeah, I think that you bring up a very good point, and you're kind of touching on the idea of trade-offs when you're deploying technology. So I can immediately tell when somebody is not very experienced in deploying technology at scale because they'll describe technology as like a silver bullet, like this is going to change everything immediately. And those of us that have been in health technology for some time, we know that there is almost no technology that doesn't have some trade-off that you're accepting. So even ambient scribes, which are the most widely adopted technology, AI technology in healthcare right now, the trade-off is that you end up reviewing your note more and maybe having to go back and edit things rather than typing it yourself and going through that sense-making process yourself. So there's really no technology that doesn't have some degree of trade-off, and those trade-offs are not necessarily very obvious at the beginning, but zooming out and thinking about the entire ecosystem of care rather than just the stakeholder that you're designing for can help you identify some of the potential implications of rolling out a technology. So one that I reference frequently is the inbox. So the patient portal in the inbox, that was a tool that was really built for patients, for them to be able to easily connect with their providers. But the unintended consequence of rolling out a tool like the inbox is that it has dramatically increased the burden on primary care providers in general, or in particular, and all physicians in general. And it is a huge driver of burnout. Now, does that mean that we should not have rolled out patient portals? No, they are a huge patient empowerment tool. But if you can zoom out and understand the ecosystem, the players that are involved, all the stakeholders that are involved, you can design systems that better support people that may be absorbing a new burden. And by the way, patients are often the stakeholders that absorb burden when we deploy technology. Sometimes the most forgotten stakeholder. But in the case of the inbox, if we are deploying it, and, we deploy inboxes sometimes to clinics that have never had patient portals before. So we think about how can we organize things like tools, how can we triage and organize these messages, how can we set up the operational systems to help clinicians be as effective and really minimize additional burden on them. Of course, there are AI tools geared towards the inbox as well, but that's how I think about deploying at scale. Is I really try to think about all of those stakeholders, who is absorbing additional burden, who's absorbing additional risk, how can we mitigate that so that an initiative can be successful. I'm sure you've seen the same when deploying virtual care and other digital solutions.
Absolutely. And I also think this adds into the shiny object syndrome of health technology. I'm sure at a health system, you are getting pitched all sorts of things all the time, and the marginal differences are very little, right? So often you have to try to sort through what it is. But as you're attesting to, and I agree, is that it's not necessarily the technology. That's not always what's going to make that much of a difference. You have to really know where it's going and what you're trying to deploy it to do. So very interesting.
Yeah. And listen, that's not always a popular answer. When you tell someone the thing that's limiting this from scaling is not your technology, it's actually some operational piece, or there needs to be some operational standardization before it can scale, people don't like to hear that, because changing the technology is the easy part, but changing the clinical and operational workflows and standardizing, that's the really tough part. But that's often that last mile of implementation depends on those structural pieces that have nothing to do with the technology.
Exactly. And I think that's why our work is important. You and I both try to fill that gap and make that very known. And so I do think there is still a lot of opportunity for people who want to get involved to make their voices known for deployment, for making sure that the right tools are developed. And so for clinicians that are listening and want to be able to add to this discussion, whether from implementation, design, or clinical informatics, but they are a bit afraid of losing touch with clinical practice, what's your advice to them?
Yeah, that's a great question. I feel like people ask me this question all the time. I'm sure they ask you the same thing, since you're, such a pioneer in this space. And I feel you were working in digital health before ChatGPT, before this became like a very popular sort of side gig, or popular area of focus for clinicians. There are so many ways that you can be involved. I took the health system route, and I started to get involved in my local health system. I thought informatics was the best avenue for me to be able to not only build skills in this area, but also gain some experience. You can start small and join committees. You can offer to pilot or test new tools. We're always looking for people who are willing to be early adopters and absorb the burden of being an early adopter. So going the health system route is one way. Another way is by pursuing something like a formal fellowship. So there are fellowship programs in clinical informatics where you can get very dedicated training in not only technology deployment optimization, but AI and machine learning. There are formal courses that you can take for, learning more about AI so that you can be a more knowledgeable user, an operator. You can start exploring with some of the vibe coding tools. I mean, those tools are really amazing. They give you the opportunity to use natural language prompts to build and design technology tools. Or you can go the startup advisory route. So a lot of folks will sort of dabble in work on the side, and I think there are many ways for you to dip your toe in as a clinician. I strongly encourage people to be exploratory with their career. I think that many of us hit mid-career, we feel very comfortable in our clinical practice, and we start recognizing that we have a lot of interest in these other areas in healthcare. And I would say that your career is never going to look the same as you thought it would when you were first-year medical students. Really put yourself out there, explore new things, and be willing to have to learn something from scratch. Be willing to be humble and become a learner again.
Yes, thank you for that. You're right. And you didn't say this, but I am going to tell the audience that basically for you, you just did it. You just started doing it. And I think that's really an incredible lesson because there is so much that you can improve by just getting involved. And I always love that part of your story. And so I think that's really something to highlight for anybody out there. And the truth is, yes, you can have a career that you could never have imagined when you're in training because you don't really know what is out there and we don't really know what's available out in life.
Yeah,
Thank you for
absolutely.
that. And so I wanted to thank you for having it. And thank you for joining me, Minal. And thank you for everyone to listening to this. This conversation sparked ideas about your own healthcare innovation challenges. Visit us at our website and explore how we can talk about this clinical deployment. I'll also share links to connect with Minal. She is really fascinating. You should definitely look at what she talks about. Thanks, Minal, for being here. And until next time, let's keep creating healthcare change that people can trust.
Thank you for having me.